objective of this lecture. At the end of the lecture, students should be able to classify antipsychotic drugs according to different aspects, to explain the basic and clinical pharmacology of antipsychotic drugs. These are some important terminology used in this lecture, as you already know: hallucination, delusion, anhedonia, dystonia, akathisia, bradykinesia, EPS, tardive dyskinesia, Tourette syndrome, and poikilothermic. What is schizophrenia? It is a genetic predisposition characterized by delusion, hallucination, thinking, or speech disturbance, occurring mainly in adolescents. The symptoms of schizophrenia are divided into positive and negative symptoms. Positive symptoms are characterized by hallucination, delusion, and thought disorders. Negative symptoms characterized by social withdrawal, flattening of emotional responses, diminished affect, impaired personal hygiene, and anhedonia. Acute episodes having mainly positive symptoms but frequently develop into chronic schizophrenia with predominantly negative symptoms. The pathophysiology of schizophrenia having different theories. The first one is dopamine theory. Evidence that schizophrenia results from excess activity of dopamine neurotransmission in mesolimbic and mesocortical pathway. There is a greater activity of D2 receptor of dopamine, so greater dopaminergic stimulation. Antipsychotic agent reduces dopamine synaptic activity. So the drug that reduces dopamine activity in the limbic system reduces psychosis. Some stimulant drugs which act through dopamine can produce schizophrenic-like behavior like amphetamine. So the drug that increases dopamine activity in the limbic system causes psychosis. Dopaminergic, this slide shows the dopaminergic system having a dopaminergic pathway and dopamine receptor. There are 5 types of dopamine receptor. These are D1, D2, D3, D4, and D5 receptor. Now the next is the glutamate hypothesis of schizophrenia. NMDA hypofunction leads to positive and negative symptoms of psychosis. Glutamate is an excitatory neurotransmitter, and NMDA receptor is a glutamate receptor. Evidence that NMDA receptor antagonists like phencyclidine and ketamine produce both positive and negative psychotic symptoms. The other theory is the serotonin hypothesis of schizophrenia. Many effective antipsychotic drugs, in addition to blocking dopamine receptor, also act as serotonin receptor antagonists. Serotonin receptor modulate the release of dopamine in the cortex, limbic region, and striatum, and also modulate NMDA receptors. It has been found that serotonin receptor blockage is a key factor in the mechanism of action of the main class of atypical antipsychotic drugs such as clozapine and quetiapine. General view that pharmacologically antipsychotic agents are dopamine and serotonin antagonists. Now come to the classification of antipsychotics. Antipsychotic classified according to different aspects. The first is the chemical type. They are classified into phenothiazine, thioxanthine compound, butyrophenone compound, and miscellaneous structures. These are phenothiazine, thioxanthine, butyrophenone, and miscellaneous structures. Another way of chemical classification of antipsychotic drugs, they are broadly classified into phenothiazine, thioxanthine, and other heterocyclic compounds. The other most important classification of antipsychotic agent, they are divided into typical and atypical agent. The typical agent further divided into low potency and high potency drugs on the basis of their affinity for D2 receptor, which influences their side effects. The low-potency typical neuroleptics are chlorpromazine, prochlorperazine, thyroidazine. The high-potency are fluphenazine, haloperidol, pymazoate. Atypical neuroleptics are clozapine, olanzapine, quetiapine, and risperidone. The typical conventional or old antipsychotic drug often subclassified according to their oral potency. The high-potency drugs like fluphenazine and haloperidol more likely to produce extrapyramidal reaction. Low-potency drug like thyroidazine may produce acute extrapyramidal reaction but more likely to produce sedation and postural hypotension. Atypical antipsychotic drugs like clozapine, risperidone, olanzapine. Clozapine is reserved for treatment of resistant patients. They have generally replaced the conventional drug for initial treatment of first episode of psychosis, and they have less extrapyramidal reaction or no extrapyramidal reaction. The mode of action of antipsychotic drugs, they block dopamine receptor in brain and periphery. Typical agents blocks D2 receptor in mesolimbic system in brain, and atypical agents have high affinity for D4 receptors, so having minimal activity for extrapyramidal effects, and also has affinity to block serotonin receptors. In short, these agents had effects on dopamine, alpha muscarinic, H1 histamine, and serotonin receptor. Clozapine are atypical agents, act as partial agonist to D2 receptor. Clozapine is an antagonist of serotonin D1, D3, and D4 and alpha receptors. It has relatively low potency as a D2 receptor antagonist. This difference in D2 receptor occupancy is probably why clozapine does not cause extrapyramidal symptoms. This table and figure shows the receptor sensitivity of antipsychotic drugs. What is the difference between atypical and typical neuroleptics? There is a no rigorous slice between the typical and atypical neuroleptic. But atypical have less tendency to produce motor side effects. Atypical produce effects on negative symptoms of schizophrenia and effective in resistant patients. Antipsychotic treatment or these drugs are not a cure. It is probably to prevent the psychotic episode than to treat them, because schizophrenia is a lifetime disease. General characteristic of typical neuroleptic: they block dopamine D2 receptors. They have motor side effects like extrapyramidal reaction. They are generally more effective against positive symptoms of schizophrenia than negative symptoms. Then the atypical neuroleptics. All atypical neuroleptics block mainly dopamine D4 receptor and serotonin receptors. Atypical agents having reduced or absent extrapyramidal symptoms. They are effective against positive and negative symptoms of schizophrenia and in patients refractory to typical neuroleptics. Absorption and metabolism: rapidly pass into brain, bind well to plasma protein, and metabolize by liver. The pharmacological effects of antipsychotic drugs. The effect of these drugs differ in normal and psychotic individuals. In normal individuals, they produce psychomotor slowing, emotionally quiet, spontaneous movement are minimized. This has been referred to as the neuroleptic syndrome. In psychotic patients, they reduce rational behavior, agitation, aggressiveness, and control psychotic symptoms. These psychotic symptoms are to reduce hallucination and delusion. These are positive symptoms of schizophrenia, blunted affect, anhedonia, impaired attention. So these are negative symptoms and mainly respond by atypical agents. Now the extrapyramidal effects. These are dystonia, Parkinson's-like symptoms, akathisia, tardive dyskinesia with chronic therapy. Antiemetic effect caused by D2 receptor of chemoreceptor of trigger zone of medulla, like chlorpromazine, produce this antiemetic effect. Local anesthetic chlorpromazine is also a potent a local anesthetic as procaine. However, it is not used for this purpose because of its irritant action. Antimuscarinic effect causes also anticholinergic effects, leads to blurred vision, dry mouth, sedation, confusion, inhibition of GIT and urinary tract smooth muscles, causing constipation and urinary retention. Also causes the blockage of alpha-adrenergic receptors, so leads to orthostatic hypotension, reflex tachycardia, and impotence. They causes altered temperature regulating mechanism, produces piclothermic, and also causes profound hypothermia and myoglobinemia, which is called neuroleptic malignant syndrome. Phenothiazine causes hypothermia. They have antagonist activity in pituitary due to D2 receptors and increased prolactin, and leads to galactorrhea and gynecomastia. They reduce gonadotropin secretion, so causes amenorrhea and fertility, and also reduce growth hormone and ADH. They act as antagonists of H1 histamine receptor and causes sedation. Now the therapeutic uses of antipsychotic drugs. Used in treatment of schizophrenia, acute mania in concomitant with lithium therapy, also used in psychosis associated with depression and Alzheimer's disease, used in treatment of nausea and vomiting, used as tranquilizer, used in chronic pain and anxiety, used in pruritus, and also used in treatment of motor and phonic tics. Antipsychotic drug also used as a pre-anesthetic medication. Neuroleptic anesthesia. Basically, droperidol, it is a short-acting and used in anesthesia for its sedating and antiemetic effect in combination with fentanyl. Fentanyl basically a narcotic analgesic. So this combination is known as neuroleptic anesthesia. Adverse effects of antipsychotic drugs. Extrapyramidal effects including acute dystonia, akathisia, Parkinson-like syndrome, including tremor, bradykinesia, rigidity, mostly caused by typical agent. The inhibitory effect of dopaminergic neuron are normally balanced by excitatory action of cholinergic neuron. Blocking of dopaminergic neuron causes excess of cholinergic influence, resulting in extrapyramidal motor effect. If cholinergic activity is also blocked, the extrapyramidal effect decreases. This achieved by giving anticholinergic drug like benztropine. Endocrine and metabolic disturbance most likely occurs with conventional antipsychotic agent and atypical agent like risperidone. Due to dopamine D2 receptor antagonist activity in pituitary resulting in hyperprolactinemia. In women causes galactorrhea, loss of libido, delayed ovulation and menstruation or amenorrhea. In men causes gynecomastia and impotence. Now then tardive dyskinesia. This is a motor disorder in which the patient displays involuntary movement, including lateral jaw movement and fly-catch motion of tongue. In prolonged discontinuation from drug, diminish or disappear these effects within 3 months. Sometimes irreversible in few patients. Tardive dyskinesia caused by oversensitivity of dopamine receptor. Now the neuroleptic malignant syndrome, characterized by muscle rigidity, fever, unstable hypothermia, myoglobinemia, unstable blood pressure. The treatment is bromocriptine, dantrolene, and diazepam. Antipsychotic drug also causes sedation due to H1 receptor blockage, drowsiness, and confusion due to muscarinic receptor. The caution and contraindication of antipsychotic drugs. Acute agitation accompanied with withdrawal from alcohol or other drugs, aggravated by neuroleptic drugs. This is stabilized with sedative like benzodiazepine. Chlorpromazine and clozapine contraindicated in patients with seizure disorder because it decreases seizure threshold. So these all are the caution and contraindication of antipsychotic drugs. Now, atypical medication. FDA approved clozapine for patients not responding to other agent or with severe tardive dyskinesia. It is effective against negative symptoms and also effective in bipolar disorder. It causes blockage of alpha-1 muscarinic cholinergic and histamine H1 receptor. This figure shows the receptor sensitivity of clozapine. Adverse effects of clozapine are weight gain, increased salivation, increased risk of seizure, and fatal agranulocytosis. Risk of agranulocytosis required continuous monitoring. Olanzapine is a clozapine without the agranulocytosis. Same therapeutic effectiveness, same side effects. Quetiapine is like a olanzapine but without anticholinergic effect. Same therapeutic effectiveness, same side effect profile. Now the risperidone. It is serotonin or D2 antagonist, highly effective against positive and negative symptoms. Adverse effects are extrapyramidal symptom incidence is dose related, alpha-1 receptor blockage effect, little or no anticholinergic or antihistamine effect. Weight gain, prolactin elevation. These are BCQs for your self-assessment. Thank you for listening to me.